Hi, everybody. Thanks for joining today on a beautiful Friday. Sorry, I gotta get where are you? Okay, good. So yeah, so great. Thanks for joining. I'm excited to talk about the new drugs and new diagnostics for this week's Pocket Talk. So thanks for joining. Again, it is beautiful out there, and it's Friday, so appreciate you being here. So what I am going to do is really try to really make a brief and practical sort of summary of where we are with the new drugs and where we are with the new diagnostics, specifically blood biomarkers, blood measures. You guys are incredibly busy. Your people are coming at you from every side. And this stuff is going to be coming at you here soon, if it's not already, the new Alzheimer's drugs and the new blood markers. And so my goal today is to kind of equip you with some of the sort of the basic but most practical information that you need, to get ready. And then I'm also going to end by so I'm going to just focus on those two things quickly at first, and then I'm going to end by talking, sort of taking a bigger picture view, and then talk a bit about what we're doing here at KU to help you. And we need you to help us help you in a way. But we're really trying to do some big things at the health system level. So I'll finish with that. But some disclosures. I do work with some companies working on new drugs and developing new drugs and also new diagnostics. And these things are really becoming a much bigger thing. So my disclosures are growing through consulting opportunities. Okay, so here's what I'm going to do for both the new drugs and the new diagnostics. I'm going to take this approach one at a time. Will they help my patient? Will the new drug or the new blood measure help my patient? Who should I treat or who should I test? What do they do, the new drugs, and what does it mean, the blood test? And then kind of what are the pros and cons? How should we be thinking about these things? So focusing just on the new drugs, these new anti-amyloid drugs, infusions, will they help your patients? The answer is really, I think, in these two figures, which is what the FDA used to approve these. Well, actually, the first one on the left is approved. The one on the right is expected to be approved really in this year sometime. Donanemab, lecanemab on the left, but they look similar in terms of their effect. And you can see that the drug is the upper line where we see slower decline over 18 months versus placebo. Now, how much slower? Well, this is 18 months, both of them. The time frame is 18 months. And we're seeing about a 30% slowing of decline. And so 30%, what does that mean? If we kind of draw a line between these two lines in terms of where somebody is on this scale, it's about 6 months. So slowing decline 5 to 6 months over 18 months is what we see on average. Very important to think about that on average, which means in the treatment group, some patients are doing a lot better than that, and some patients are not responding at all. And so on average, we can expect about a 30% slowing of decline. That 5 years ago, we were dreaming about having this opportunity to have a 30% slowing of decline. Now we're here, and the debate is how the cost benefit ratio and is it really worth it? That's for, I guess, the field and you to decide. But I think this is an important, my take as I'm sitting with patients and talking to them is it's an important opportunity that we should discuss and offer to patients. Not all of them want it, and not all of them are right for it for various reasons, but a 30% slowing in this kind of clinical and functional and cognitive decline, these measures, is important to the point where the FDA has approved the drug on the left, lecanemab, and is expected to approve the one on the right. So in terms of will it help your patients, it can. But we have to be careful about who we treat, which I'll talk about in a second. But yeah, right now, who should we consider this for? It's really for patients with mild disease. So people with mild cognitive impairment or mild Alzheimer's disease. And so people in the early stages of decline, in the sort of pre-dementia stage where there's clear memory decline, clear change from prior, levels of memory performance, or the MCI stage, or people with mild dementia, who it appears to be Alzheimer's, we should be thinking about this as an option. Now, there's a lot of other things to think about, and I don't have a lot of time to get into it, but I will touch on it a little bit more later. But we have to consider, do they have amyloid in their brain? As we'll talk about next, these drugs go after amyloid. And so we have to confirm the presence of brain amyloid. And we need to think about the adverse events that we see primarily around bleeding and edema that can happen. And so we need to think about things like, do we see microhemorrhages on the MRI or evidence of hemorrhage in the brain, superficial siderosis, or past hemorrhage? So are they on anticoagulation? They can be on anticoagulation and get these drugs, but the appropriate use criteria generally recommend against that. And so we're learning more about that. So that's a big consideration, is, are they anticoagulated? And then their ApoE genotype, do they carry an E4 allele, and which can increase the risk of these side effects? But if they have 2 copies, it increases it quite a bit. So there's some things we have to think about. But in general, the type of patient that you can think about, all right, is it appropriate? Do I want to even think about it or have a discussion or refer? It's patients in the mild stages, MCI or mild Alzheimer's disease. So what do the drugs do? Well, they target amyloid. They're monoclonal antibodies against amyloid, and they reduce amyloid from the brain in patients who have amyloid in the brain. And that amyloid is part of the definition of Alzheimer's disease. And so by giving these drugs, right, the lecanemab is given every 2 weeks by infusion. The donanemab is given once a month by infusion, not approved yet, but in a treatment period of 12 months to 18 months, we see dramatic reduction in the level of amyloid. Figure on the right, that yellow line dropping down is a treatment group, and that's a pretty dramatic reduction, as exemplified in the Cover of Nature article from 2016, where we are now able to influence this key protein that is sort of part of the Alzheimer's process. We don't understand exactly what part of the process it is, but it's part of the process. And by removing it, we can see, that 30% reduction. But what are the pros and cons? How should we approach, treatment? Well, we got to think about pros and cons, or the benefits versus the risks and costs and burden. And so the pros talked about 30% slower decline over 18 months. What we don't know is what happens, a year later after that 18 months, or 5 years later after that 18 months. And we are looking for more and more data to help inform. Is it really just something we see over 18 months, or do we see long-term benefits? Don't know that yet. I'm hopeful, but we don't know that yet. So right now we can at best expect, on average, 30% slower decline in really key cognitive and functional outcomes. But what are the cons? There are cons, of course. Safety, I've touched on a little bit. The burden of receiving this drug, and the cost, which I'll get into just a little bit more here. So safety, infusion reactions. We do see the first couple infusions close to 20-25%. We're seeing this here, have infusion reactions that are generally tolerable, or we can reduce with pre-treatment, and they tend to decrease over time. But the key one we worry about is this ARIA, amyloid-related imaging abnormalities. In about 1 out of 5 patients treated, we're seeing some form of ARIA, which is pictured on the right, edema or microhemorrhages, or little evidence of hemorrhage. Most of the time, this is only seen on MRI. It's not seen in terms of symptoms. So patients don't really complain about it, but we see it because we're looking for it. We see it with MRI only. And it's pretty manageable by stopping the drug or holding it for a while, and monitoring. So, but about 0.7%, so about a little less than 1 out of 100 have a serious side effect, meaning a larger hemorrhage, or the edema is leading to symptoms like more confusion or even a seizure. And so that's what we worry about. And that's what we have to be really mindful of, is those serious side effects that we can see. So safety is something we really have to consider first and foremost. And we can actually begin to understand how high somebody's risk is based on that ApoE genotype. So if they have 2 copies of the E4 allele, they're at about 45% risk of having RAS. So there's some ways to kind of get a sense of, are we at higher risk or lower risk in this? So, but burden's something we have to talk about. This is a little bit of a lifestyle change for people. They got to get an infusion every 2 weeks. And so where do they live, and is it how big of an issue that is something that really needs to be considered. And all the eligibility testing, is a bit of a burden. And then the monitoring, we monitor with MRIs after pre-treatment, but also at 2 months, 3 months, 6 months, and 12 months during the course of treatment. So these things add up, and they add up in terms of cost too. So, but the drug itself, at least lecanemab, is $26,000 wholesale, which means it's higher for them. There's infusion charges, there's MRIs, there's office visits. Now, Medicare has so far done a pretty good job of covering these costs, but people will still have a copay in many cases. So, and insurance companies are coming around, but and so we spend a lot of time in our clinic sort of managing these issues. How do we steer people through these issues of denials and et cetera? So a lot to think about. And so just to sum it up, so why consider it? Well, we can get a 30% slowing on average, which means some patients do better and some not. And we're really trying to understand who in that group is going to respond and who's not. And I think in a few years we'll be better at predicting that. Who really, MCI or mild dementia, really, if you use the MMSE or something like it, scoring 20 and above is where we want people to be. And it appears that earlier is better. What do the drugs do? They reduce brain amyloid as a monoclonal antibody infusion. What are the cons? We have to really balance and think about and weigh in really pretty lengthy discussion with patients and families, safety, burden, and costs. And so really important to walk through that and have time to do that. Okay, so that's the drugs, and I'm going to come back to some of this, but now let's talk about the blood measures. There are new blood measures. You can get these now. And in about 3 months, we expect you at KU will be able to order these. Not FDA approved, but order them, and we'll come back to you with information on this, but order them through our Brain Health Care Accelerator program. But these measures are here, and they're coming, and they're going to come at basically be available to everyone, probably within the next year or two. And what do? Well, they basically detect the presence of brain amyloid with pretty good sensitivity and specificity, good enough to be useful, very useful. And so what are the benefits? Why might you consider this? Well, I think the role is obviously diagnostic. This can really help increase the confidence of a diagnosis in those who have cognitive impairment. If we have somebody who has clear cognitive impairment, that's somebody who you may benefit by using these tests in. And it also can help guide treatment considerations. So do we want to go down the pathway of new therapies, and potentially can we spare people from lumbar punctures or amyloid PET scans? And so we think these markers, because they're scalable, because they're simple, are really going to help change the field and move things forward. So who should you consider testing? I think really it's only in people who have a clear history of cognitive decline or dementia. So if somebody has consistent, progressive, even if mild, but progressive changes where they have changed from, where they were before. If you're getting a good history of change from their prior level of function or the prior level of memory performance, then this might be somebody you want to test, especially if you in the office do a screening test and they screen positive for cognitive impairment. So these are not tests yet for patients who don't have cognitive changes. They're not screening tests that could be used in people without memory problems. That's really important. We're working on that, and I'll talk a little bit about it in a second, but it is not something that in a population of people without cognitive changes that has really been proven to be helpful, proven to be good enough, have enough sensitivity and specificity or positive predictive value, negative predictive value in that population to be useful. So we want to be careful with who we use it. Patients who have a good history and are at risk, strong family history, or their age above 55 is really the right population to consider these in. And so what do the tests mean? What do they do? Well, they reflect the presence of brain amyloid. And if you do it, there's three cut or there's three or two cut points, but three categories. If they are not elevated, they're unlikely to have amyloid in their brain or unlikely to have Alzheimer's pathology in their brain. If they're intermediate, it's too close to call. And if they're elevated, then we can, with 90 to 95% sensitivity and good specificity in the 90%, it really supports the likelihood that somebody has Alzheimer's related brain changes. So if you use it in the right context, it can really support this diagnosis of Alzheimer's disease. But it alone, especially if we choose the wrong population, is not a diagnosis. It just reflects the presence of this pathology in the brain. So did you know that 25% of normal older adults have brain amyloid? This is where we get we have to be really careful with how we interpret and who we test this in. 25 to 30% of normal older adults over the age of 65 without memory decline have brain amyloid. And so that's really important to remember and to know, using it in people with cognitive impairment is important. Now, we on the research side, and, when I moved to the research side, I am incredibly interested in this population, and we are actually targeting this population with studies where we're trying to understand, can we use drugs like lecanemab in this population to prevent them from developing Alzheimer's? We don't know it yet. We're still testing it. It's going to be a few years before we know it. So just know that that's coming. We're working on it, but these tests are not something that are going to be useful for a while in that population of people without memory problems. So what are the pros and cons? Well, the pros are, as we talked about, it can support, it doesn't make, but it can really support a diagnosis of Alzheimer's disease by giving you information regarding the likelihood of the presence of Alzheimer's pathology in the brain, or amyloid pathology. And then your diagnosis that the cognitive decline is related to Alzheimer's disease can be enhanced. And so it's something also to consider as a screen for new anti-amyloid therapies, the new drugs, where if somebody is, without a doubt high on that test, we think in the future we may be able to spare them from a lumbar puncture or an amyloid PET. And so that's an area of research. We're moving kind of quickly into that direction as we get these biomarkers in our hands and get a better sense of how sensitive and specific they are. So the cons are not for screening asymptomatic people, and a lot of people who are at risk are going to want these tests. And you need to be a little careful with how you give the information back. It can provoke anxiety. You need to think about insurability. If you're using these on the right patients with cognitive impairment that's documented in the chart, I don't know if we have an issue with insurability there, because that alone would impact their long-term care insurance that they have cognitive changes. But it is something to think about, especially if we're straying into those who are asymptomatic or at risk or really, really early. So those are things to think about. And so, back to the big picture, why consider them? Well, it can increase diagnostic confidence. It can help us understand, should we even head down the route of anti-amyloid therapy? MCI and dementia, I think if you have people really across the stages, probably most useful in the early on, but if they have dementia, if they have clear cognitive change, we can use these markers. What do they mean? They support the presence of brain amyloid. So we have to interpret that in the context. It's not a diagnosis, but it supports the presence of amyloid in the brain, which, as I mentioned, a lot of people have, and they live with it fine. Many of them are probably at higher risk of developing Alzheimer's, but they can live with it. And then the cons, anxiety and insurability, things to think about. How do you deliver the information? How do you communicate it? So, okay, so that's it for those two things. Now I want to kind of take a step back a bit here and just kind of think about MCI and dementia and the continuum of cognitive decline. And so mild cognitive impairment, what is it? It's generally amnestic. It's generally memory change without obvious functional impairment, but clear and observable and by history, but also measurable on testing. We can see memory changes, whereas everything else might be good, but memory is impaired on testing. And that could be in the office, remembering the words and, today's date or day of the week. Those are often signals that there's a memory change and everything else might be good. And if you pair that with a strong history of memory change, then you have a pretty solid diagnosis of mild cognitive impairment, the syndrome of mild cognitive impairment. Dementia is where we see that cognitive change get to the point where functional day-to-day activities are beginning to get interfered with. And but what is dementia versus Alzheimer's disease? The number one question I get is, what's the difference between dementia and Alzheimer's? And dementia and Alzheimer's both have the same syndrome, and that's memory and thinking problems that interfere with daily function. But the causes of dementia are many. The cause of Alzheimer's are plaques and tangles, the picture here on the right, which shows under the microscope plaques and tangles of somebody who had the syndrome of dementia. And so Alzheimer's is a specific form of dementia, accounting for about 60% of all dementia, where we see plaques and tangles, amyloid plaques, the big splotches sort of in the upper part of the picture are amyloid plaques, and then the tangles are beneath that. And so that's the definition of Alzheimer's: amyloid plaques and tangles in somebody who has the syndrome of dementia. So important to keep that in mind. We're now at a point where it's going to become routine for us, not just on the research side, but routine even in primary care, to detect the amyloid plaques and tangles in the brain with measures like, we've been doing lumbar punctures, we're doing PET scans, but now blood. And so really pushing us forward. And important to consider, all right, when we're seeing people with mild cognitive impairment or cognitive impairment in the mild stages, even mild dementia, we got to think about heterogeneous etiologies. Not all of it is Alzheimer's. It is, if it's dementia, it's the most common form, but there's things we have to worry about, think about, look for. But now we're going to very, very soon, in the next few months, but definitely in the next year or two, across all primary care, we're going to be able to use these biomarkers to understand, is there a likelihood that we're dealing with brain amyloid or the pathological changes of Alzheimer's, to help us sort through all this. So I'll just summarize a few things important in early recognition, important history, sort of questions to ask and to dive into. You can do this pretty quickly, but I know it's hard and a busy practice with short appointment times. But are they forgetting details of recent events? Do they need help keeping their calendar? Are they having difficulty navigating in unfamiliar places where before they would have navigated there well? Is their judgment and problem solving maybe good, still good, but maybe not as good as before? It's a really good question to ask. It's good, but not quite as good as before. And why? Maybe they're having a little trouble paying the bills, following recipes, things like that. So fixing things around the house. So these are some key good things to really try to probe on. And with a good history, along with the proper tests and supported by the new biomarkers, I think we're going to get much better and much more efficient at making a solid diagnosis of Alzheimer's and early dementia. But no single test makes it. Really takes a detailed history where we look for those characteristic, progressive, consistent changes in cognition. Ideally, you get that information from a caregiver or somebody who knows the patient well, a spouse, a kid. Run the test, do a physical, make sure we're not missing stroke-related or Parkinson's-related changes. Blood tests, rule out thyroid and B12. MRI to rule out structural problems, and consider depression, medications, and sleep apnea, and maybe test for sleep apnea if it's on the if it appears to be possible. And now, consider blood biomarkers to help support the diagnosis, or consider anti-amyloid therapy. So now you can tell it's pretty complicated to help to decide if somebody's a candidate for these drugs, and probably something that you'll need a specialist for. And so we've created our anti-amyloid treatment clinic, which is a subclinic of our memory program here. And the idea here is this is collaborative care where we can work with you to support your patient's access to the new therapies. We can do the workup. We can support this and the discussions to help support the selection of the right patients. Is it right? Are they eligible? But then is it right for them? And that's two different things. Are they eligible? We check all the boxes, but then is it right for their risk tolerance? Is it right for their lifestyle and all that? So we can treat and then we can monitor with the serial MRIs and the office visits and address any AEs that we see. And so this is something you have patients that you think are a candidate for. We have created capacity there primarily through a team-based effort led by APPs with my support. But the APPs doing the workups and the check boxes, and then me doing e-consults to ensure that sort of that things look right. So if you refer to neurology in the memory clinic, if you specify, consider anti-amyloid therapy, something about that, then we can get them into that clinic pretty quickly. So much quicker than if they get at the back of the line for the full memory clinic, diagnostic clinic. But this is a collaborative clinic, meaning we're supporting you and your care of the patient. We're really trying to keep it purposeful around anti-amyloid treatment. We can't do the full diet, we can't do all the other things that, say, our memory clinic does. So it's a different model, collaborative model. And so what do? We actually work through this checklist, which I've kind of outlined already, ensure they are in the mild stage. We might test them if we need to. We test for elevated cerebral amyloid with an LP or an amyloid PET scan to confirm it. We will ensure there's a baseline MRI that's less than 12 months old to rule out those problems, and we get the ApoE genotyping. And so we work through this checklist and make sure that they are eligible, and then have the discussion to make sure that that it's appropriate and right for them. And so just to remind you, we do confirmatory. These blood biomarkers are good, but they're not always confirmatory. And so for a while, we'll probably rely on confirming the presence of brain amyloid through an amyloid PET or a lumbar puncture. And so, yeah, we're using that right now. And then I'll just wrap up. We're running out of time, but with what's coming soon, what are we working on? I've been working on this for a good year. Is what we call our Brain Health Care Accelerator, where we're really trying to address this need. Big population, primary care cares for probably more patients with dementia than we do. I think that's true. We're looking at trying to get our numbers from our health system, but you're caring for the patients. And so how do we do better? How do we support you so that, and so here's how we're doing it through this Care Accelerator funded by the Davos Alzheimer's Collaborative. We're one of 4 sites in the country, along with Case Western, Mount Sinai, and Wake Forest, chosen to be in this program, where we are testing the implementation of health system-wide effort to improve screening. Our design, what we're doing at our site, every site is different, is working hard to develop new screening tools for you to implement these blood biomarkers in practice before they're FDA approved in the research stage, and then build out these collaborative care models, beginning with the anti-amyloid treatment clinic, but hopefully moving quickly to a comprehensive memory support program for those in the sort of moderate stages of dementia. And so we're really working hard to try to design and invent a new standard and a new model for dementia care. I don't believe, and you probably agree with the wait times you hear about or rejections you might get when you refer patients, that standard memory clinic is not the ultimate answer. We can't just triple or quadruple the size. We've got to come up with new tools and new ways to do this. Now, memory clinic, there's always going to be a place for that, but it alone can't just be scaled up to do this. So, and I believe a collaborative care model where it is a part of that solution. So I'll end there and say thank you.